Back again to simple complex, simple CTO lesions or simple CTO case. I have a man, he's hypertensive 5 years ago and type 2 diabetes. The first onset angina was 1 year before the coronary angiography, and he was diagnosed as an ischemic heart disease only 1 month before the angiography. He had a positive stress test, and it was positive in the intraventral wall ischemia, and the coronary angiography was done. We have blood system injection. Second branch is totally occluded, and there is a lesion in the first branch. It's a large vessel. It's a tight lesion, and as you see, there is a related collaterals to the right coronary from the left system. Again, there is a filling of the right coronary system from the left system. And so we don't know the onset of this, the occlusion of this right coronary, whether or it is a year ago when he started to complain. Here, the total occlusion of the right coronary artery, proximal total occlusion with, I think, JCTO score +2. There is an ambiguous occlusion because there is a branch at the side of the occlusion, maybe tapered, so maybe 1 over 0. No previous trial and no calcification, and I think it is like about 20 millimeters. And there is an intercoronary collaterals from the right to right collaterals, as we see. Again, the right coronary. So the decision was to start PCI of this CTO occlusion, and then as all of us when we start the CTO PCI, there is a dilemma of choice of the tools, whether to start with a simple wire or complex, make it complex. I usually use to make it simple as possible as I can. So I started with H2MS guide wire, and then pilot. I went to pilot, I think 550 wire, and there's a cross of the lesion. There is a bend of the lesion in the lesion, so it may be score 3 because of the bend. And there is no support the guiding here, as we see. When I started to support the wire with the Artimes balloon, the guiding, but I could cross more of the lesion a little bit forward. So succeed to cross with further balloon support, as we see that it is more distal than the previous picture. And at this time, I thought in the use of the audio wire, or the use of anchoring wire in this branch, but I tried at this moment, I think in the use of the anchoring wire and another wire to cross, but I tried manipulation and then finally crossed with the support of the 125 balloon, 1 by 12, and then started redilatation, and again flow is resumed. And as you see, that's a long lesion, long total occlusion segment, and a larger balloon dilatation was done. Further balloon dilatation, then long 2.75 by 48 science expedition stent, DS stent, started at the origin and the ostium of the RCA because all of these segments was diseased, and then flaring of the stent, and this is the final result of this CTO RCA lesion. The patient was free of symptoms for about 6 months, and then despite there was a lesion in the circumflex second diagonal, and so I thought that these lesions were responsible for the symptom of the patient, and decided to do coronary angiography again. And as we see that the here second diagonal, it's not a small branch. As we see, that's a very large area. It's showing the fainting collaterals. It's not small. It's a long artery, but the caliber is small. And the lesion in the OM branch is a 90% lesion, and surprised that we have instant restenosis in the right coronary, and I think this segment was pre-dilated during the previous procedure. So I decided to go first with this dilatation and with drug balloon. And I think this is the final result. Then to make it, to close his subject and symptoms, I decided to go to the other vessels affected, other affected vessels. So I started to do the intervention. It's a tortuous vessel, as you see. Then finally crossed with the stent, and in order to avoid putting it in the circumflex, and put it in the proximal segment in the ostium. So adjusted and expanded. So finally, I decided to go to the second diagonal branch, and as we remember that it was 9 months ago occluded, and maybe more than this time. It is at the origin. Some colleagues said that leave it and don't injure the LAD. Again, support with a balloon, Artimes balloon, and I could cross the lesion and did pre-dilatation and resumed the flow. So the decision now is whether to do a drug balloon or to put a stent in this long disease segment. We don't have drug balloon available all the time, and because of the expenses, sometimes we use the stent rather than cheaper than the drug balloon sometimes. And so I did the balloon dilatation, the Artemis balloon, and started stenting of the diagonal branch without LAD compromise, and so this is the final result. And summary, Artemis balloons are now a good weapon tool in our hand to achieve a growth of the CTO and successful CTO PCI.
Thank you, Dr. Mahmoud. That's some nice, interesting cases.
Thank you, Jim.
I think it's been a fairly interesting session. Thanks very much to BrosMed. They've been quite regular with these webinars, getting speakers to share their cases and helping us learn from each other. Also meeting some new friends along the way. So we'll wait for some questions to come. And as we move along, I'll just post the questions, and if any of you guys want to add anything, please feel free to go ahead. So there is a question here: what's your regular use atmosphere for Apollo? Well, it depends on what my inflation device allows me to go. So if I can go higher, I'll go as high as I need to and can.
With me,
any other questions from the experts?
Yeah.
Yeah.
So I just want to say that BrosMed is on a good track. I have used a lot of balloons from a lot of companies, and the problem, we have also some reimbursement issues and cost problems in our country. So the one affordable best balloon in Turkey is now that from Apollo. Of course, I have different channels. I can also have a lot of different balloons, but the 1.0 balloon, the CTO balloon is fascinating. And if something happens, I have also used the regular balloons, balloon uncrossable CTOs and something like that, and septal pre-dilations, and Artimes in that sense helped me a lot. And if Artimes does not go, I have not seen any other go as well. So I just want to say, keep doing the good work with these balloons. And the NC wedge, about the NC wedge, there should be a way to have an FDA approval for the NC wedge balloon that we use, that is designed for peripheral intervention. Because if we can use this 3-wire balloon over the balloon with 3 wires in the coronary, I think we will change the game a little bit more to another frontier. That's my opinion. That's how I see it. But another thing is, we should have the right tools in our cath lab. If we should have the right tools, if we don't have a scoring balloon, if we don't have a rota, if we don't have a good NC balloon, then I think it is the best for the patient to refer it to a surgeon than to go and try to solve the problems with the means that we have. That's not a good way, because you end up with a lot of complication. My perforation rate almost went to 0 when I began to use rotablators, scoring balloons, cutting balloons, and prepare the lesion as it should be. My perforation rate downs almost to 0. I had a lot of complications in the past, and the reason was the cost issues. You have a balloon and you want a balloon that has a back profile. You cannot cross. You push it, you try anchoring, you try different solutions, and then you go to high pressures, and then you end up with complications and perforations. So you have at least prepare the lesion in a proper way if you do with calcification and complex lesions. If you don't have that expertise, and if you don't have the necessary means in your cath lab, I think one should refer the patient to a surgery if it's an LAD. That's what I have to say.
That's a very interesting take, Dr. Shafir. I absolutely agree with you. You know, sometimes when you're trying to cut costs is when you really run into trouble.
Yes.
Saying I've used a NSD scoring element when really high pressures, ruptured the left main, you know, have to put a covered stent in the left main. Yeah, so that can be quite scary, you know, when you could have got away with the initial arthrectomy or now with the shockwave balloon and whatnot. Yeah. So, Dr. Sarman and Dr. Mahmoud, would you guys like to add anything on the session? Or?
Yeah, it was nice talks and discussions, and I kind of just add one tip, like when you're doing a pre-dilatation, I use mostly just for getting access, I get Artimes, and then for proper doing it, you also do the NC balloon for pre-dilatation. I take for the 3 mm vessel, I take 2.5 NC, I go up to 24, just to break it, whatever is there. So then only you can get a 3 mm stent properly deployed, and then a 3 mm post-dilatation. So suggestion is like pre-dilatation with a non-compliant balloon is definitely useful, especially you can avoid. If that's not expanding, then you know there's something wrong, and then you go for the next level of preparation, cutting balloon, scoring balloon, or IVL, whatever. So I just like to break the whatever the tissue, tough tissue before you put a stent in, rather than struggling later. There's one question about how much atmosphere you go with the Apollo. Like you said, like 24, 26, 28 till the end, no problem. But almost never use non-NC balloon for 12, 14. That's you don't need. There's no point near 12, 14. If you're using NC balloon, you at least you go for 20 plus. There's no point using a non-compliant balloon less than 20. Of course, you have respect the size of the artery. Can oversize it.
Thanks, Dr. Sarwan. That's an interesting take. I think a few years ago, I can't remember, it's like maybe 6 years or 7 years ago, I read a paper that mentioned that the optimal atmosphere for an NC balloon is 21 atmospheres. I'm not sure if anybody remembers this paper or not, but it's been quite a while. I can't remember exactly what the paper was. Yeah, so you're absolutely right. If you're going to take NC, you got to go high pressures.
Yes. Dr. Mahmoud, do you have any suggestion or a supplement? Hello, Dr. Mahmoud. Yeah. Okay, now we can hear you.
Because we in the last minutes I have interruption of the voice, and I did not hear you very well, and all of those. I think it's an internet interruption. So I'm sorry. Are you going to ask? Would you like to ask anything? Do you have any question? You hear me?
Yes, yes, we can hear you. Yes. And no more question from the audience. Yes. And okay. So thank you. Thanks for all the experts, and thank you for today's wonderful presentation and comments. It's very helpful to us with many insights and tricks on the complex PCI. And thank you for all your experience and the trust and support for BrosMed. It was a great honor, and we will keep going to bring our products for excellence. And dear audience, and for more product information, you can search BrosMed website or contact us via email sales@brosmed.com.
So I have another suggestion, if I'm allowed to say. So I would like to have, of course, we didn't have share any cases with intravascular imaging. So intravascular imaging is also an essential part in my complex procedures. And sometimes I see left veins like 6O. Okay, so there is only, I think, 6O balloons from SIMPAS, and there are 6O balloons from, I think, from Boston.
Yes.
And I let SIMPAS make the balloons special for me. They make a special series 6O balloons. Sometimes you need 6O balloons in left veins. If you have intravascular imaging, and in intravascular imaging, I do all my left vein cases with IVUS. So I don't do any left vein cases without IVUS anymore. It was in the past. And it changed my maneuvers, it changed my technique completely after using IVUS. So my other suggestion is, if you can provide us with 6O balloons, it would be awesome.
Okay.
That's my other suggestion.
Okay.
6O balloons.
Okay. Thank you for the new marketing input. Yeah, I will transfer to our R&D team and try best to make the second generation PDCA with the size.
So as Jaja has said, he has not 30mm balloon. So 30mm balloon is a good marketing direction. So we need it if you do complex, and it's the same. We need also 6O balloons. So that's it.
Okay, thank you. Yeah, BrosMed will also try our best to meet the clinical and the physician's needs.
So we have 10 minutes left. I think that's the reason why I am talking so much. If anyone want to come in and have suggestions and have any comments, they are welcome. Jaja, I am not hijacking your moderator position. I'm just trying to.
This is a very casual chat among friends, you know.
Yeah. So we have time.
Carry on this.
And I see Michelle is struggling and want us to say something. I have a lot to say. I can also tell you some jokes if we have time, so no problem.
Okay. Okay, thank you. Thank you. And I will arrange another meeting with our leaders and to discuss with you for lots of new products. Yeah. Thank you. Thank you all the experts, and thank you for the audience. Looking forward to see you next time. Okay. Bye-bye.
Okay.
So
bye-bye.
Thanks
Bye.
everyone. See you guys. Bye. Have a good weekend.